Hello everyone, thank you for joining us today. My name is Amanda Toll from Extra. Welcome to our Clinical Education Training course. I'm pleased to welcome Dr. James Wilson, an oncology skin cancer specialist working at UCLH and with London's leading private hospitals. Dr. Wilson will speak today about non-surgical solutions for skin cancer and the role of radiotherapy. This course offers a very comprehensive overview of the role of radiotherapy in the management of non-melanoma skin cancer. Dr. Wilson will share his experience and clinical case studies on the role of radiotherapy in the management of his patients. Thank you again for your attention, and with that, I welcome Dr. James Wilson to today's session.
So thanks very much for that introduction, Amanda. So my name is James Wilson, and I'm here today to talk about non-surgical solutions for skin cancer, specifically the role of radiotherapy. Now, I could have also called this talk Skin Cancer Radiotherapy for Non-Oncologists. So I'm presuming that the audience are people who may have contact with patients with skin cancer, but don't necessarily treat it with non-surgical techniques. So you may be GPs, or dermatologists, dermatological surgeons, plastic surgeons, or other healthcare professionals. And I hope whichever group you're in, you're able to get something from this presentation. Just to narrow down a little bit, I'm specifically talking about local treatment options for localized non-melanoma skin cancer, with a particular emphasis and focus on basal cell carcinoma and cutaneous squamous cell carcinoma, as they're the most common skin cancers that we're all seeing in our clinics. So what we're going to talk about today. Firstly, we're going to characterize risk in non-melanoma skin cancer. We're going to briefly look at what all of the local treatment options are. So that's all the treatments aiming at local control or cure of the skin cancer. I'm going to tell you when I recommend radiotherapy, and we're going to talk about the different types of radiotherapy. Now, for non-oncologists and non-radiation or clinical oncologists, the radiotherapy pathway can be quite not very clear, and the route from me meeting a patient in clinic to them completing the radiotherapy can be a bit of a mystery if you're not used to seeing patients during radiotherapy. And I like to think that's predominantly because radiotherapy departments tend to be in the basement of hospitals and people don't come and see us. But I would recommend that you reach out to your radiation oncology colleagues. I'm sure they'll be more than happy to welcome you into the department to demystify what's actually quite a straightforward process. We're going to talk a little bit about treatment schedules. We're going to talk about the side effects of radiotherapy, and I'm going to talk about that in the context of how I consent patients. I'm going to briefly talk about how I follow patients up, and at the end, we're going to discuss the 3 priorities in deciding on which treatment modality you're going to recommend for a patient with non-melanoma skin cancer, and that's the likelihood of cure, how convenient it is, and how scarring the treatment's going to be. How good is a cosmetic outcome going to be from the treatment that you recommend? So let's make a start. So I'm going to talk a little bit about Mohs micrographic surgery, just in case there are any non-dermatological specialists out there. Now, I would say that Mohs surgery is the international standard treatment for localized non-melanoma skin cancer. Now, how is this different from standard excision? Well, what's happening is the surgeon is removing the tumor layer by layer, and at each point of excision, the surgeon is getting live feedback from the pathologist as to whether the margin is involved or not. The tumor is sampled in multi-planes and from multiple sections, so that the area where the tumor is still present can be identified both by the pathologist and the surgeon keeps removing tissue until all of the tumor has been removed. And this means that the chances of having a positive resection margin and therefore a risk of recurrence in the future should be a lot less with Mohs surgery. It should also mean that you can have tighter margins on your surgery so that the amount of tissue that you're removing is less. So in theory, the cosmetic outcome should be a lot better than with standard excision. Now, that's all well and good, but when I'm seeing a patient presented in our multidisciplinary team meeting or tumor board, I'm always thinking about what is the surgical defect going to be like and how involved is the reconstruction going to be. Because the complexity of the reconstruction also tells us something about the cosmetic outcome for this patient. I'm also thinking about how complex that reconstruction is in the context of the general health of the patient. Many of the patients that are referred to me are frail and potentially have lots of comorbidities. That would mean that doing an involved procedure that would require either a local flap or transfer of tissue from one part of the body to another to fill a defect just isn't going to be possible for that patient. However, if it was going to be a small amount of tissue removed and we could close the defect by secondary intention or a simple suture, then I think that that patient, even if they are frail, has all of the options available to them. So I've always got this reconstructive ladder in the back of my mind, in the tumour board, when I'm thinking about the treatment that we're going to recommend for the patient. So what is radiotherapy? Now, radiotherapy is actually very straightforward. And what I say to patients is radiotherapy is just the use of X-rays to damage tumour cells. How does it do that? Well, the way that it does that is through DNA damage. It does that by both direct and indirect damage. Now, what we're trying to do during a course of fractionated radiotherapy is produce lots and lots of double strands DNA breaks in the tumour. Now, inevitably, we're going to cause that similar damage in the normal tissues as well, because the DNA in the normal skin cell right next door to the keratinocyte that's caused the cancer is exactly the same. The difference is that compared to normal tissues, the DNA repair mechanisms in cancer cells is deficient. So if we were able to accumulate DNA damage throughout the course of radiotherapy, then the cancer cell is less likely to be able to repair that damage, so that cell's much more likely to die. We've got lots of ways of delivering these X-rays to the cells. First of all, we've got the X-strahl system, which delivers superficial or orthovoltage energy X-rays. Now, the energy of the X-rays tells us how deep that X-ray is going to penetrate into the tissue. Next up from there, we have a megavoltage linear accelerator, and there are lots of different manufacturers of these. This is a variant true beam. Also, we have a slightly newer treatment, something such as the OncoBeta produced rhenium SCT, and we're going to talk about that a little bit later. This is adding a radioactive paste that emits radiation to a depth of around 3 millimeters. We'll talk about that later in the presentation. So how do we define risk? So I'm going to talk a little bit about risk features in basal cell carcinoma and also in squamous cell carcinoma. So with basal cell carcinoma, we look at the clinical features, or what we get from the patient history and examination, and also what we get from the pathology report of either the biopsy or the information we get from the excision of the tumour. In terms of clinical features, we're looking at where the tumour is on the body, the size of the tumour, the borders, are they distinct or indistinct? Whether it's a primary or a recurrent basal cell carcinoma, whether the patient is immunosuppressed, either by medication that they're on or other health problems such as lymphoproliferative disorders. And I also want to know is if this BCC is occurring at a site of previous radiotherapy. When I get the pathology report, I'm looking at the growth pattern of the BCC, the differentiation of the tumour, the level of invasion and depth of invasion, whether there's any perineural involvement, the TNM stage, and also the margins of the resection if an excision biopsy has been done. Now, when it comes to location, there are certain high-risk locations, and we often talk about the H zone, which we can see in this image here, which is in the temples, around the eyes, around the nose, and around the mouth. Now, any BCC in that area should be considered high risk because of the potential for deep infiltration. In the light shaded areas of the face, so the cheeks, the forehead, and the neck, then BCCs in those locations are considered high risk if they're more than 10 millimeters. If the BCC is elsewhere on the body, in the trunks or in the extremities, they're only considered high risk if they're more than 2 centimeters in diameter. Clinical features, location and size, we've discussed. Borders, I'm more concerned about poorly defined lesions because of our confidence in getting a clear resection. Primary tumours are lower risk than recurrent tumours. Patients who are immunosuppressed are at higher risk of tumour recurrence, and lesions that have been treated before with radiotherapy are much more likely to come back than de novo tumours. So what are the pathological high-risk features? So in terms of growth pattern, it's the infiltrative types of BCC that I'm concerned about. So they'll be reported as being infiltrating, morphaic or micronodular, and the superficial or nodular BCCs are lower risk. In terms of differentiation, I'll be looking to see if the pathologist has commented on basal squamous differentiation, whether that's present. Level of invasion, I'm worried about invasion beyond the subcutaneous fat, and also tumours that invade more than 6 millimeters. Perineural invasion makes a tumour high risk and actually puts it into the PT3 category because of the nerve invasion. T&M staging, T2, T3 and T4. So what that means is more than 20 millimeters and or major bone invasion puts the tumour in the high risk category. And involved margins, so that's microscopic margin involvement or close, as in tumour extending to less than 1 millimeter from the resection margin, makes this lesion high risk, and we consider some further treatment. So once we've worked out the risk category that the tumour fits in, what are our local treatment options? So for low risk tumours, we've got everything at our disposal. So standard surgical excision, topical therapies such as imiquimod or 5-FU, cryosurgery, triple CNC, photodynamic therapy or radiotherapy. For high risk tumours, we've got Mohs surgery or standard excision if the tumour is located on a body part that allows an adequate margin for standard excision. Now for high risk and for patients who are medically or technically inoperable, either based on the location of the tumour or the patient's general health, then I'd always recommend radiotherapy. For patients with advanced disease, we have the sonic hedgehog pathway inhibitor, vismodegib, for advanced disease. Also, we mentioned earlier, and we'll come back to, we've got topical brachytherapy with rhenium SCT. Now, where that fits in the UK is currently up for discussion, and we'll talk about some of the early clinical trial results from use of this new treatment. So when do I offer radiotherapy for basal cell carcinoma? So I'd offer it for older patients, and by older, I mean those over 60 years of age with low or high risk BCC. In those who've declined excision or Mohs micrographic surgery, if they have a preference for radiotherapy, if they have nodular BCC, or if they have an infiltrative BCC, but I can apply a suitable margin to my radiotherapy target, that means that I will capture any microscopic tumour extension. I tend not to offer radiotherapy for BCCs that have recurred following radiotherapy previously. Certain genetic syndromes that predispose to skin cancer, such as xeroderma pigmentosum or Gorlin syndrome, radiotherapy is really not good news in those patient groups. Now, I wouldn't offer radiotherapy to areas of poor blood supply, and the most common area that this applies to is the lower limbs, and we often see tumours on the shins of patients, and radiotherapy isn't my preferred option for those patients. Now, young patients need very careful counselling. Now, I usually don't offer radiotherapy to patients younger than 60 because of the radiotherapy late effects, specifically the secondary malignancy risk. Now, the level of risk that I quote to patients is 3 in 1,000 at 5 years or 5 in 1,000 in 15 years after radiotherapy. But what I also counsel about is that the type of tumour that radiation can induce, albeit the risk of that being rare and many years into the future, the tumours that it can induce tend to be a lot more aggressive than something like a BCC. So they need to be aware of that risk before consenting to treatment. And the traditional teaching is that we wouldn't offer radiotherapy or prefer radiotherapy for basal cell carcinomas that involving bone and cartilage, just because the chance of controlling that tumour with radiation is reduced compared to surgery. Now, I put a little star by the next to not preferred there, because when I was preparing this slide, I can think of exceptions to pretty much all of these, apart from the genetic syndromes, where I have treated people in that setting with appropriate counselling, and that's usually because they don't have a surgical option. Defining risk in squamous cell carcinoma is in many ways very similar to basal cell carcinoma. So we're looking, and I'm not going to go through all of this slide, this is from the British Association of Dermatologists clinical guideline. And again, similar to BCCs, the risks in squamous cell carcinoma are based on tumour factors such as size, thickness, level of invasion, how well or poorly differentiated the tumour is, perineural invasion, whether that's present or not, and then certain histological subtypes which are high risk, such as adenosquamous tumours, desmoplastic tumours, spindle cell sarcomatoid, or metaplastic squamous cell carcinomas. So they're the things that we look at in the pathology report. We're also interested in the margin, and just like BCCs, I want a margin of at least 1 millimetre and ideally more to say that we're happy with the level of resection. In terms of patient factors, immunosuppression is again very important, and the most high risk patients that I see in my clinic are the people that are immunosuppressed. So I see lots of people with squamous cell carcinomas after solid organ transplants, and also as people are living longer and we're seeing more CLL, I'm seeing a lot more patients with CLL in my clinic, and some of their squamous cell carcinomas have behaved very aggressively. We'll come back to how we follow these patients up once we talked a little bit more about the treatment. So when do I offer radiotherapy for squamous cell carcinomas? So I offer primary radiotherapy as a single modality treatment when surgery just isn't possible, when surgery would cause unacceptable functional or aesthetic outcome, or in selected cases after MDT or tumour board discussion, we always need to be factoring patient preference into those decision-making processes and tumour board discussions. In terms of adjuvant radiotherapy, I recommend adjuvant radiotherapy for squamous cell carcinoma when it's been incompletely excised and further resection is not possible without causing functional or cosmetic deterioration. When there's perineural invasion, so that means multifocal small nerve involvement or the involvement of a Naden nerve greater than 0.1 millimeters in diameter or nerves below the dermis. I recommend adjuvant radiotherapy for recurrent disease and also in all immunocompromised patients. I discuss adjuvant radiotherapy, and I also discuss close clinical follow-up when the margin is clear but close. For completely excised T3 tumours with multiple high-risk factors, such as being 6 millimeter thick or invasion beyond the subcutaneous fat. So I'm now going to talk a little bit about how I go about making a treatment recommendation. So when do I recommend Mohs? I recommend Mohs as my first choice for poorly defined tumours, because of that constant feedback from the pathologist, you're not going to leave any tumour behind, even if they've got an infiltrative subtype and the margin was very difficult to define or describe even under magnified light. I want some reassurance from the dermatological surgeons that they can achieve a clear margin with a minimal amount of tissue resected, so that we're not left with a defect that's very difficult to close. And I'd also want to recommend Mohs in tumours arising in abnormal skin that's unlikely to heal well. So when do I offer radiotherapy? So the traditional teaching with radiotherapy is that cosmesis and functional outcome is better with radiotherapy when you treat within the facial triangle. So the facial triangle includes the inner and outer upper eyelid and the lower lid. It involves nasal lesions and lesions around the lips. And the traditional teaching has always been that the functional cosmetic outcome is better with radiotherapy for lesions in those locations. I also tend to err towards radiotherapy for tumours in the H zone, because I'm going to examine the tumour carefully. In selected patients, I'm going to get imaging if I'm concerned about deep infiltration along soft tissue and bony planes in those locations. I also recommend or tend to err towards radiotherapy for lesions in the pinna, because I've seen patients go for Mohs on the pinna, and then them requiring an extended resection, which to my eye leads to a very poor cosmetic outcome. And I think I've got an example here to show you. So this is a chap I met in clinic with a very well differentiated squamous cell carcinoma of the pinna. And before I met him, he'd been counselled by a surgeon that he was going to need to lose a significant amount of cartilage from his ear. Rather than doing that, I offered him 5 fractions of radiotherapy using the extral system. And this is his outcome. I think this is 6 months, because I followed him for 6 months after treatment. He had an acute skin reaction, which we'll come to, but that lasted less than a month. And his ear looked like this, essentially from 4 weeks after the radiotherapy finished. He was very pleased with the outcome, and I was very pleased with the oncological outcome, because throughout follow-up, this tumour hasn't recurred, and he didn't need to lose any skin or any cartilage to get that excellent treatment result. So other factors that I consider when I'm choosing radiotherapy over surgery is patient preference, and that's really important. We need to tell patients what outcome they can expect, or what success looks like with the treatment that we're recommending. So I like to meet patients at the same time as the dermatological surgeons wherever possible, and we can both talk about the pros and cons of our treatment approach. I like to keep this reconstructive ladder in mind that we've discussed already, and when we're getting up to the free tissue transfer or the local tissue transfer, so when we're doing flaps for nasal lesions in elderly patients with multiple comorbidities who have a limited life expectancy because of their other health problems, I question whether we should be doing that. And we have quite a frank conversation between me, the surgeon, and the patient sometimes, so that we know that the patient's making the right choice for them with all of the information they need to make the decision that they want. I also tend to offer radiotherapy when there are multiple lesions, also in patients who are prone to keloid scarring, because they tend to get a better cosmetic outcome with radiotherapy. I tend to offer radiotherapy for large lesions that would require mutilating surgery, particularly around the nose, ear, and around the eye. Most of my patients are elderly, and they also tend to have comorbidities that mean that any surgical procedure would be high risk. The most common reason that I'm referred to patients is because patients are on anticoagulation, and stopping that anticoagulation for surgery is either high risk or it would just cause logistical problems for the patient. I'm less likely to recommend radiotherapy for young patients because of radiation-induced malignancy. I'm repeating myself here, but I think it's important. I'm also aware that in young patients, that cosmesis following radiotherapy will deteriorate over time. So if you have somebody who, if you cure their skin cancer, they're going to live another 20, 30, 40 years, I tend to offer surgery rather than radiotherapy, because we know that we can achieve better long-term cosmetic results with that. I don't offer radiotherapy to areas of poor vascular supply, or areas such as elbows, where it's surprising how often we knock our elbows in day-to-day life from resting on tables and desks. So I tend not to offer radiotherapy there, because it can take a long time for them to heal. Now, when there's bone, cartilage, or tendon involvement, surgery tends to be the patient's better option, unless surgery is going to be very mutilating, in which case I'd counsel the patient about the likelihood of success, and success being cure for that individual patient based on the extent of other soft tissue involvement. And we've talked a little about the genetic syndromes where I don't offer radiotherapy previously. So let's talk through the radiotherapy planning pathway. So once we've made the decision as a team that includes the patient and their wishes, what do we do to get the patient started on radiotherapy? So the first thing we do is we consent the patient, and then it's my job as the oncologist to think about patient position and immobilization. We then define the target, as in what do I want to treat, and do I need to apply a margin to make sure that we don't leave any tumor behind. I think about the radiotherapy technique I'm going to use. I then define the beam that I'm going to use to treat the cancer. I think about how I'm going to manage exit dose, because unfortunately the radiation doesn't stop in the tumor, and some radiation will always extend deep to the tumor's boundaries. So I need to think about how I'm going to manage that to reduce side effects. We're going to talk a little bit about what bolus is and why we need it. And then we're going to document the setup so that then when the patient comes back for treatment each day, the radiographers know how to set the patient up to guarantee an accurate treatment to maximize our chance of cure. And then we're going to get started with the treatment, and the treatment is going to run as per my treatment prescription. So let's talk a little bit about consent. I do this in the clinic when the patient has had a conversation with me and any other healthcare professionals that they need to speak to before they come to a decision. The decision is theirs to make. Now, as part of that discussion and as part of that consent process, the patient needs to know the treatment intent. By that I mean, am I aiming at curing this tumour, or is it about shrinking, controlling, containing the tumour for a period of time? I also want to be confident that the patient knows what their alternatives to radiotherapy are and why they've come to the decision to have radiotherapy rather than one of the alternatives. And I'll often explore that with them as part of my consent process. I then talk to them about the radiotherapy treatment schedule, the number of fractions of radiotherapy we're going to give over how many weeks, and also how long the treatment's going to take. For something like the extral system, I explain to them that the beam is usually on for less than 2 minutes, but I tell them to count on being in the radiotherapy department roughly half an hour a day. And that's because by the time they arrive at reception, check in, wait their turn on the radiotherapy machine, walk down to it, get in the right position, have the treatment, and then get back out to their car or onto the tube or the train or however they got there, that usually takes about half an hour. Before we sign the consent form together, we need to talk about side effects. So I split those up into acute toxicity. So that's side effects that happen during and just after radiotherapy, and late toxicity. So late toxicity is any side effect that occurs months or years after the radiotherapy is finished. Now, when it comes to acute toxicity, I always explain to patients that the side effects of radiotherapy build very slowly during radiotherapy, and they often don't reach a peak until just after the radiotherapy is finished. So it's very important for me that I see patients in the week after they completed the radiotherapy, because that's often when they're struggling the most. And often what they need at that time point is encouragement that these side effects are temporary and they will get better. And something else that some patients find challenging is that the side effects get better the less that you do to them. So usually it's about just biding your time and waiting for them to pass, and use the gels and ointments that we provide for you, but just try to live your life as normal. So what are the side effects? So the acute side effects are skin redness, soreness, discharge, and scabbing. And then there are site-specific side effects depending upon where we're treating on the body. So if you're treating the nose, you could get some nasal mucositis, which causes discharge and stuffiness. If you're treating the lip, then you could get some oral mucositis, which can be quite sore. Now, the side effect that nobody seems to avoid, even if you're treating quite a small skin cancer, is fatigue. Now, what I encourage patients is that I tend to see them a week after radiotherapy is finished. At that time point, the side effects are usually at their worst. And then, particularly in the NHS, I then don't see them until the fourth or fifth week after radiotherapy is finished, at which point I expect the side effects to be fully resolved or resolving. In terms of late toxicity, I tell them about skin pigmentation change. So the skin in the treatment area can be slightly lighter or darker than the surrounding skin. The skin can be slightly thinned in the treated area, both because of the effect of the tumour that's been eradicated, but also because of the radiotherapy. We talk about telangiectasia, which can occur at a higher density within the radiation field, and I tell them about hair loss in the radiation field, which will be permanent in the majority of patients. Now, what some patients worry about is they're going to lose all of their hair. They get confused between the side effects of chemotherapy and radiotherapy. Now, the only hair that's going to be lost is the hair that's within the treatment field, and I'll be able to describe very clearly to the patient where that hair is and how much is likely to be lost before they start. We've talked about radiation-induced malignancy, but I do talk to the patients about that where appropriate before they sign the consent form. I also use this opportunity to talk about how they're going to care for their skin, both during radiotherapy and lifelong. In terms of during radiotherapy, I ask them to do as little as possible to their skin. So if it's in the beard area in men, I ask them to stop shaving in the area of the tumour. I ask them to stop using soaps or anything that could dry the skin in the area that's being treated. And I ask them, when they do have a shower, that when they get out, they don't rub the area dry with a towel. We want to do as little as we can to irritate the skin, and also to, once the skin starts to heal, to minimize the chance of impairing that healing by removing the new skin cells as they come in. In terms of lifelong advice, we talk a lot about using high SPF, sun avoidance, and things like wearing a hat and covering the skin from direct sunlight for long periods. So the next parts tend to happen in the radiotherapy department when the patient comes for their clinical markup appointment. So I'm going to talk to them about the position they're going to be in. I'm going to decide with the radiographers whether the patient is going to be supine or prone or sitting. Now, one of the good things about the extraoral system is we've got very frail patients, particularly if they've got things like heart failure, that we don't need to lie them down flat, which can be quite distressing for patients when they're receiving radiotherapy. So the extraoral system gives us lots of flexibility, which means we can treat patients who perhaps couldn't be treated in other ways. We make them as comfortable as possible. We use head rests and knee rests to make sure that the patient is comfortable enough to lie still during the treatment. And if I'm treating the head and neck, particularly around the eye or other sensitive structures, I tend to recommend an immobilization device as well, just to increase our confidence that the patient isn't going to move after we've set them up for their radiotherapy. So here's some different setups. So this is the extraoral system, and you can see that the patient in this image is semi-recumbent, which is a very comfortable position to be in. And it means that we can confidently leave the patient in the room while they have the treatment without worrying that they're going to become uncomfortable and move to become more comfortable. Here's another one on the patient's face, and you can see the flexibility of the extraoral system, which means that we can position the unit so that it delivers the x-rays in a way that's comfortable for the patient. This is an electron setup. So in not every institution has the option of using superficial x-rays to treat cancers, so they need to use a mega voltage machine. You'll see this, when treating with electrons, most commonly you need the patients to be comfortable lying on a flat, hard bed, which limits the ability to apply this to every patient. There are exceptions to this, and particularly for palliative treatments, I do relax the immobilization that I insist upon when using electron treatments for those patients. So back to our pathway. So once we've got the patient in position, I need to decide what my target is. And when I'm looking at the lesion that I've decided to treat under magnification and with bright light, I document the size of the lesion and its site. The size influences the type of radiation I'm going to use and the dose and fractionation. We'll come to that later. I define the edges and I comment upon whether all of the edges are clear or whether they are indistinct. And that makes me then think for areas of indistinct edge, I add more of a margin to make sure that I capture all of the tumour. I then assess the depth of the lesion, so I need to be present for this process, and I examine and I assess whether the tumour is invading deeply and whether it's invading into structures underneath the skin, because that will influence the type of radiation I use and the energy of that radiation that I'm going to use. I look at the surrounding skin and I comment upon it, kind of trying to preempt any healing issues before treatment starts. And I use this as my last pre-treatment examination of the regional lymph nodes. I've often done that in clinic, but I like to do that again and document my findings before we start the treatment. So as I said, I assess all of these lesions under bright light and magnification. I have to be there because this process relies both on clear visualization of the tumour, but also palpating the tumour edges and also palpating the tumour to see if it's fixed and also how deep it is. I then draw on the patient and I generate what we call a CTV. So that's a margin around the edge and at depth. We must always remember that we're not just adding a margin for uncertainty around the edge of the lesion. We want to treat a little bit deeper than the tumour that we can either visualize or feel to mop up or treat any tumour extension deep to the lesion. Just having another drink, excuse me. So those margins I apply are different for BCCs and squamous cell cancers. So for a nodular BCC, I'm probably going to be happy with just a 5mm lateral margin and deep margin on my GTV. For infiltrative subtypes, where I'm less certain on the edge of the lesion, I tend to add a centimetre. Or for large or very poorly defined BCCs, I'm going to increase that margin around my visible tumour by 10 to 15mm. For squams, I tend to add a larger margin. So for squamous cell carcinomas that are less than 5cm with very clearly defined edges, I'll add 10mm or a centimetre to my visible and palpable tumour. For larger lesions or those with poorly defined edges, I'm going to add anything to 15 to 20mm beyond the visible and palpable tumour. Now, for all of these lesions, I'm going to add at least 5mm at depth to ensure that we don't experience a late tumour recurrence. Now, for certain sites, I'm going to treat the full thickness of the tissue, such as the pinna or the nasal ALR. Of the eyelid as well. Then in terms of thinking about the depth, it's going to be the full thickness of that tissue, and then my lateral margins are standard as we described previously. Now when it comes to the radiotherapy technique, I need to decide on what type of radiation I'm going to use, whether it's going to be superficial X-rays or orthovoltage using something like the X-RAL system, or whether with lesions that are deeper, then we can treat with superficial X-rays. I might think about electrons, and for very large lesions, or when there's nodal involvement, I'm going to treat with photons. I'm not going to talk much about photons today. So when I'm deciding on my beam type and energy, I want to make sure that all of my tumour and the margin I've applied to that tumour receives at least 90% of the dose that I have prescribed. Now, for superficial or orthovoltage X-rays, I can treat up to about 2 centimetres. Electrons can treat up to about 5 centimetres in depth, and photons are used for much larger lesions. Now, special circumstances, the X-RAL system is particularly useful for lesions around the eye, and we're going to talk a little bit more about that later. Electrons are not great for very small lesions because our modelling of the electron dose distribution sort of breaks down below 4 centimetres. So I try not to use it for very small lesions. It is more useful for lesions overlying bone or cartilage, and that's because of something called a photoelectric effect when using superficial or lower energy X-rays. And I try to avoid using electrons over body cavities because the deep penetration part of the electrons can extend right across that cavity, and you can end up with side effects or symptoms some distance away from the lesion you've treated, which is obviously to be avoided. When I'm thinking about my dose and my fractionation choice, in the UK, we've got very clear guidance. So I'm a fellow of the Royal College of Radiologists, and they have a recommendation document for the doses and fractionation that we should be using, which is updated regularly. Here's their current guidance for the radical curative treatment of squamous cell carcinoma and basal cell carcinoma. So the doses and fractionation recommended by the Royal College of Radiologists is a single fraction of 18 to 20 gray. Now that's for small lesions, so where my field size is less than 3 centimeters, and I would only ever use that schedule in cosmetically insensitive areas, so parts of the body that are usually not seen, mainly on the trunk in an elderly patient. So that's when I would use that treatment option. Now, the vast majority of my patients actually receive 35 gray and 5 fractions over 1 week, or 45 gray and 10 fractions over 2 weeks. And I tend to use more fractions in cosmetically sensitive areas because the cosmetic outcome is better the more you fractionate the treatment. Now that means, as you can see, I also have options to fractionate even more, and in patients who are very cosmetically sensitive, I will use something like 55 gray and 20 fractions, or even 60 gray and 30 fractions. Now, if I'm treating a very large lesion or a lesion that is spread to the local regional lymph nodes, I'm going to use 60 gray and 30 fractions over 6 weeks. So that's quite an investment for the patient in terms of their time and commitment to come for that treatment. So, as I've just said, the vast majority of my patients receive 5 or 10 fractions. I'd say that's at least 90% of my patients. In very frail patients who would struggle coming for 5 treatments on 5 consecutive days, I do use a Sandbrook split. Now that's using 24 gray and 2 fractions, and there's a 5-week gap between the 2 fractions. And I find that to be very helpful, and I've had some very good cosmetic and oncological outcomes with that treatment. We've discussed already when I use 2 gray per fraction, so 60 gray and 30 fractions over 6 weeks. That's the areas of low radiation tolerance. So if I ever have my arm twisted to treat a lesion in an area of poor blood supply, this is what I would use, or in cosmetically sensitive areas in younger patients, or in tumours overlying sensitive structures. And the most common area is that I think about 60 in gray and 30 fractions is for lesions over the medial canthus, which can potentially lead to damage of the nasolacrimal duct. And I think that's a toxicity I like to avoid, because living with a watery eye, I think, is deeply unpleasant for patients. So defining the beam. So how I define the beam depends very much on the energy of the particle I'm using to treat. So for superficial or orthovoltage lesions, here you can see a setup of the extraoral system, and you see this lesion can be successfully treated with an 8-centimeter circle lead cutout, which is applied directly to the patient, and then the applicator from the extraoral system sits flush with the lead cutout and treats the lesion very safely with that setup. Electrons, we tend to use thicker cutouts, and the cutouts go to the end of the applicator. So that wouldn't be applied to the patient, that would be attached to the radiotherapy machine, and that defines the beam that then goes on to treat the patient. So I popped to, this is in UCLH, which is where I have my NHS practice, and you can see here, these are the lead cutouts in our superficial radiotherapy room. So these can be reused after being properly cleaned and sterilized between patients. And we have a number of lead cutouts that we already have. So in many patients, we can see them, do the clinical markup, select the lead cutout that we already have made up, and we can start treatment later the same day after a few simple calculations. You'll also see on this image, you can see my cursor, we have some wax-covered eye shields here and some wax-covered nasal plugs, which we'll come to in a minute. Now, these lead cutouts are very easy to make. We have a mold room at UCLH, and if we have quite an eccentrically shaped tumor volume, we can very easily make a customized lead cutout, in a few minutes, to allow us to then treat the patient promptly. So how do I approach the patient when I'm treating with electrons? So this here is a cross section through an electron beam when it hits the patient, and there's a couple of things that I want to point out. So the grey shaded area here is the tumor that I want to treat, and what I always want to be aware of is that I want all of that tumor to be combined within the 90% isodose. So everything within this area here is receiving 90% of the dose that I prescribed. Now, one thing that I also want to be aware of here is this grey box is sort of a representation of how large my beam is. So you'll see that this here is the patient's skin surface, the line here. You'll see that to treat a tumor of this size, I need to use a beam size that's a little bit larger than the tumor that I want to treat. And that's because of the, I'm not going to get too much into the physics about the beam characteristics, the dose or the percentage dose of the beam constricts within the tissue. So to make sure that 90% is covering this area, I need to treat a little bit bigger. So that's, in my mind, another downside to using electrons. You have to treat a larger area of tissue to safely treat and ensure that the tumor gets the dose that you want it to get. And this is what the depth of different electron energies look like in the patient. And there's a few things that I want to point out here. First of all, this is the depth dose curves for an electron beam that is 8 centimeters in diameter in a circle, because the shape and size of the beam change this depth dose curve. One thing I want to comment upon is this is the dose at this patient's surface. So at a depth of 0 centimeters in the patient, the lower energy of electrons aren't delivering 90% to the tumor surface. And when we're treating skin cancers, we want the surface to be receiving 90% or higher of the dose that we've prescribed. A nice characteristic about electrons is that the dose falls off very quickly within the tissue, but we need to be aware of this therapeutic range here. So how long or how deep is this 90% in the patient? So this is the useful area of this electron dose distribution. So anything from this depth to this depth is receiving 90% or higher of my prescribed dose. So this is what I'm thinking about when I'm prescribing or deciding on my electron beam to treat a skin cancer. What I actually get is a table that looks a bit like this, which tells me if I use 6 MeV and a field of these sizes, this is where the dose is deposited within the patient. So for a 3 by 3 centimeter beam using 6 MeV energy beam, I get 90% of my dose at 4 millimeters in the patient and also 1.6 millimeters in the patient. So if I want the surface to be getting 90%, I need to think about this 0.4 millimeters somehow. And we'll come back to that now. So the other thing about electrons is, if you're not treating a flat surface, the distribution of the radiation deposition can change considerably. So this is an illustration I produced from a CT scan showing the electron dose distribution when we just apply an electron beam coming anteriorly directly onto the nose. And you can see that because there's not enough tissue here, there's no tissue, it's just air, we're not getting enough contribution of dose from the air, so the nose is a bit too cold, and in this area here it's getting a bit too hot. So what we need to do is we need to provide tissue equivalent around the nose, because the electron needs to come into this tissue to then generate radiation, which can cause DNA damage within the target that we want to treat. So for electrons, the planning of treating slightly eccentric surfaces such as the nose is a little more challenging and requires a lot more planning and pre-planning to make sure that we can get the dose in the area that we want it to be and avoid hotspots. That being said, here's a patient that I've treated with electrons on the nose, and you can see that she has an infiltrative, crusting, diffuse BCC on the tip of her nose. And then this is her nose just 6 weeks after the treatment finished. And you can see that there's no evidence of any residual tumour on her nose, and she hasn't lost a significant amount of tissue. And my concern for her was if we were to offer her Mohs, I think the resection would have ended up being quite extensive, and I think she'd have lost a significant amount of cartilage from the nose, and we would have changed her facial appearance considerably. The next thing I need to think about when planning a patient's radiotherapy is the exit dose. So the radiation exit path deep to the tumour needs to be taken into account, because that tissue is going to receive a dose of radiation, and that can lead to side effects such as mucositis or cataracts. Here you can see I've got a picture of some lead contact lenses or internal lead eye shields that we use when we're treating lesions on the eyelid. So you can see they come in various sizes. We put some local anaesthetic drops into the eye before putting the contact lens in. Now, to me, these look quite uncomfortable, but once you've had the local anaesthetic drops, the patients tolerate them incredibly well. We pop this in just underneath the eyelid before starting the treatment, and then take it out as soon as the treatment's delivered. Now, one thing that I need to counsel patients about before they have the eye drops is that they will then need to wear an eye patch for 3 or 4 hours after the radiotherapy. And that's because if you have an anaesthetized eye, you're not going to notice if you get any grit in the eye, so you're at risk of corneal aberration. Now, one thing that I would comment on here is that the side effect that I'm trying to reduce the probability of here is cataract. So as long as I can cover the lens with the lead, I can be confident that I can keep the risk of cataracts in these patients as low as possible. And actually, one of the lesions that I like treating, particularly BCCs, is of the eyelid, because some of the cosmetic outcomes we get are very. So what is bolus? So bolus is really something we need to think about with electron treatments. So bolus is just a material that has a similar electron density to tissue to make sure that the surface of the tumour gets the right radiation dose. You can see here we have a picture of tissue equivalent bolus that we can put on any part of the body. Now, it is quite flexible, you can manipulate it, but particularly in areas such as the eye or around the nose, getting this tissue to sit flush with the skin so that there are no air gaps between the bolus and the skin is incredibly challenging. So we need to do something a little bit more involved than commercially available bolus. So here's the electron and superficial X-ray depth dose curve that we talked about. So the X-axis is talking about depth within the patient from when the beam meets the skin. And this is the percentage of the radiation dose along the Y-axis that's being delivered. Now, the beauty of superficial X-rays or orthovoltage X-rays, which are the solid lines, is that 100% of your dose is deposited at the skin surface, which makes these wonderful for treating skin cancers. Now, if I wanted to treat a lesion that's at the skin surface, so at 0 depth in the patient with electrons, unfortunately, with this 6 MeV voltage beam, I wouldn't be getting enough radiation dose at the surface, so it's less than 80%. So what do I do if I'm at a center where I don't have access to superficial X-rays? Well, what I do is I add bolus, and I work out how thick my bolus needs to be to ensure that when the beam enters the patient, that the dose is at 90% of the dose that I prescribed. So that's what bolus does. It essentially pushes the surface of the patient further away from the beam. It provides tissue to allow the generation of secondary electrons in the tissue so that we can damage the DNA at the surface of the patient, even using an electron beam, which should only be able to do that deeper in the patient tissue. So bolus is important for that process. Now, as we just said, we don't need bolus when we're using superficial X-rays. It's only useful when we're using electrons to bring the treatment dose up at the skin surface. Air gaps really need to be avoided because they can really affect the dosimetry. So if we want to be confident about the dose that we're delivering to the tumour, we need to be sure that there are no air gaps between our bolus and the skin. We can also use bolus to produce a flat surface so that we can give accurate electron treatment similar to the nose that I showed you earlier. Now, this is a slide that was very kindly provided to me by some of my physics colleagues. Now, this is what it used to be like when I started training in radiotherapy, and the process of producing a shell that we could then use to produce customized shielding and bolus for a patient was incredibly involved. It required the patient to lie flat and for us to produce a plaster of Paris impression of their face or whatever body part we're trying to treat, and then use that plaster of Paris impression to produce a lead mold or mask, which we then could cut out where the tumour is. Now, that would be a very long process, which would take days to weeks and is incredibly labour intensive and has a number of points in the pathway where minor errors could be introduced. So we have a much more modern solution available to us now. This is how we use a 3D printer. So here we are scanning a patient's face. So we're using an infrared device to be able to map out the geography and the surface markings of this patient's face. We're able to do this to produce a 3D representation of the area that we would like to treat. This information is then sent off to a central lab, and we're able to get renderings like this. And using these renderings, we're then able to do use a 3D printer to produce an acrylic mask or shell, which we can then, I think the red thing there is just to add some additional support at an area of weakness. But you can see there, that's a very quick process, and we get a very accurate reproduction of the patient's surface anatomy. We can then use that 3D printer and you see here that on this photograph, before scanning the patient, we put some surface markers on which the device can detect. We can then accurately cut out the area in the lead mask to make sure that we're exposing the exact right amount of skin to make sure that the beam is covering all of the area that we need it to cover. We can then use the 3D printer to produce the bolus that we need. So this is producing a customized wax bolus where the electron field can be applied directly to the end of this to this device, and we know exactly how thick that wax is, and we know that it's sitting flush to the patient's skin because we produced a 3D rendering of the patient. Now, this hugely increases the accuracy of electron treatments, and I consider this to be a huge step forward in the accuracy of our radiotherapy. Here's some examples of a patient that I treated recently. So you'll see that this is a lesion on the nose, which I needed to treat with electrons, a lesion on the forehead. And then this next patient here on the right is this is some 3D printed bolus for a patient I actually treated with photons. So I had a patient with a BCC on either side of the nose, and they were going to be treated at a centre that didn't have superficial X-rays. And what I was concerned about is if I was using an electron beam from the left and an electron beam from the right, then we're going to get an addition of the dose in the midline of the patient. And I was concerned about severe skin toxicity along the nasal bridge. So instead, we did a 3D printed bolus, and I was able to treat the patient with a photon plan. And this is the very nice, neat photon dose distribution that allowed me to treat both sides of the nose with a high degree of accuracy. Now, this is the patient at the end of treatment, and again, 4 weeks after the treatment finished. I saw this patient a week after radiotherapy finished. She was incredibly distressed, as I think I would be if my nose looked like the nose on the left. It was very sore. You can see that the radiation reaction has extended into the cheeks a little bit. There's lots of crusting. Some of the crusting had just come off, which had caused some bleeding. She also had significant nasal congestion. I was able to settle this down. I gave the lady a silicone gel to use to keep the area moist. I even gave her some nasal steroid spray to calm down the nasal mucositis. And then when I saw her just 3 weeks after the picture on the left, this is what the nose looked like. Now in follow-up, she's got an excellent cosmetic outcome and the cancer hasn't come back. So I'm very pleased with her treatment result. So the last thing is to document the setup. So this is the forms that we use at UCLH so that we've captured everything that we need. So when the patient comes for treatment every day, we know exactly how to set them up and make sure that we're delivering exactly the same treatment. So that covers both how we're positioning the patient and also the beam characteristics that we're using. So how far away is the applicator from the patient's skin? What shape is the lead cutout? We always label the lead cutout, so we're just using them for one patient for the duration of their treatment. We've measured the lead cutout, so we know we're using exactly the right one, and we check that before each treatment. The energy of the superficial X-rays that we're using is documented there, as is the thickness of the lead cutout, and we've taken a photo of the patient to keep it accurate. Now, the other thing we do, particularly when we're using the XRAL system, is sometimes the low-tech solution is the easiest and best one. So the radiographers use an acetate to identify key landmarks of the patient before setting them up for their treatment. So you'll see here, they've identified the patient's nose, eyes, lips, eyebrows, and hairline, and they'll put this acetate over the patient, and they can then see where my tumor volume that I delineated is, which is the red line, and also what my target volume is. So I want them to treat everything within that blue dotted line, and then they have the individual lead cut out for that patient, and then know that they're treating exactly the point on the patient that we want to see. This might seem like we might not need this because the lesion should be very obvious, but as we progress through treatment, particularly through fractionated treatment, and we're starting to see some skin reaction, it can be harder to see the lesion, particularly when we're seeing some response in the cancer that we're treating. So once we've done all of this, we're ready to start treatment. So I've got a few cases that I wanted to discuss with you, if that's okay, just an example of how we approach these. So this is a 72-year-old man that I saw in my clinic, and he had a history of CLL, so he's immunocompromised. So by the time I'd met him, he'd already had a surgical excision because the dermatologist that met him was confident that this lesion on his skin was a squamous cell carcinoma. When we got the histopathology back, this was a moderately differentiated squam. There was invasion into the reticular dermis, so that's into the deep part of the dermis. That's a Clark level 4 lesion. There was perineural invasion present. The margins were clear, and there was no local regional lymph node involvement. I mean, there are a number of high-risk features in this case: the history of CLL and the immunocompromise, and the invasion into the reticular dermis concerns me, as does the presence of perineural invasion. So when we discussed his histology at our tumour board, I recommended post-operative radiotherapy. So this is him when he came for his radiotherapy markup. So you can see that we've defined the limits of his surgical scar, and we've added a margin to capture any microscopic infiltration of any residual tumour. So this is what he looked like at the start of radiotherapy. You can see this is just after the radiotherapy finished, and you can see that there's significant erythema. There's been some crusting and scabbing, which is now starting to lift. And also you're starting to see that he's got some loss of his beard within the treatment field. And you can see on the patient's skin exactly where we've treated, which matches the target that we delineated at the start. And this is how his skin looked 3 months after the radiotherapy finished. I'm not happy with this cosmetic outcome. I think that he's got some pigmentation change. There's still some ongoing erythema. There's some skin atrophy. There's some increased pigmentation around the margins of the treatment field. However, you know, the patient disagreed with me. The patient was very happy with this outcome, and you can see that he's still lost the hair within the treatment field. So he's got permanent hair loss within the treatment area. The next case is, this is an 81-year-old female patient I saw, and she had an infiltrative basal cell carcinoma on her nasal tip. I was concerned that if we were to go in and try and treat this with Mohs surgery, the amount of resection, and the loss of tissue could be considerable to get a clear margin. I therefore recommended radiotherapy. So this is how she looked at before the radiotherapy. This is when she came for her markup. So you can see that under magnified light, we've defined the gross tumor volume with this red line here. So you can see the area of crusting in the middle and the raised edge on the all the way around. And then we've added a centimetre all the way around the lesion because this is an infiltrative subtype of basal cell carcinoma. This is how she looked a week after radiotherapy, and she was pretty cross with me. So you can see that the whole area of tumour has crusted and there's significant erythema around the lesion, and she was quite sore. I need to give her some simple analgesia. I recommend some paracetamol and a non-steroidal anti-inflammatory because she found this quite painful. We also talked about management of her nasal discharge. So this is how she looked 3 months after the radiotherapy. Now my feeling is I was quite happy with this outcome. You can see she'd already lost some tissue because of the destructive nature of the BCC. So there is some tissue loss in the center of this lesion. There are some telangiectasia within the treatment field, but I think with I think it would be very difficult to notice this if we were to meet this patient for the first time, and if you were to wear some makeup, we could even out the changes in the pigmentation of the skin. However, this patient is deeply unhappy with this cosmetic outcome, and she comes to see me regularly saying that she thinks that the outcome is poor. However, I think this is a good outcome, and this is just to show how what I consider to be a good cosmetic outcome isn't always what a patient considers to be good. I think we need to be very clear when we set out on treatment that we're both aware of what we consider to be a successful treatment. I've got another case here. This is an 83-year-old man who presented with quite rapidly evolving lesions on his scalp. This started just 3 months ago, and you can see on the left-hand side there's a smaller lesion, and on the right-hand side there's a much more substantial skin lesion. He'd had a biopsy by the time I met him. He had a punch biopsy, and they were both moderately differentiated squamous cell carcinoma. Because of some concern about lymph node involvement, and also because he has 2 lesions, he'd had a CT head, neck and chest. I was very pleased he had a CT head because I could look for any bone involvement deep to these lesions, and thankfully there wasn't any on the CT. And also there were no lymph nodes involved on the CT, and there were no metastatic deposits within the thorax, which was very good news for him, as it meant we could just offer him a local treatment to these lesions. We discussed about a multidisciplinary team or tumour board. He had multiple comorbidities, and my feeling was to resect both of these lesions in a man of 83 with all of his other health problems was too big an ask. I think to be able to close these lesions, he's going to need quite an extensive reconstruction, perhaps even with a tissue expander, or even using a flap from another part of the body. I was therefore keen to offer him treatment with radiotherapy. So here he is when he came for his radiotherapy treatment markup. The lesions are very easy to see. We put a generous margin around both of these lesions to give him the best chance of cure. And this is how we looked when he came to my clinic 3 months after the treatment had finished. Now, personally, I'm very happy with this outcome. You can see there is some loss of tissue at the site of the previous lesions, but I put that down to tissue destruction as a result of the cancer and not the radiotherapy. He's very pleased with this outcome, as am I. There are a number of high-risk features in this patient. He is immunosuppressed, so we're keeping him on very close follow-up. My next case is a 69-year-old man. He's also got multiple health problems. Particularly, he's got health problems that require him to be anticoagulated. He's got atrial fibrillation. He also has heart failure. He has epilepsy and learning difficulties and autism. He also has hypertension. He presented with this round plaque with some ulceration in the center. There are some rolled edges which don't come across particularly well in this photograph. And this lesion was bleeding quite a lot when I met him. He'd had a biopsy, and this was a nodular basal cell carcinoma. The MDT felt that to excise this, he'd require extensive reconstruction, and there was high operative risk, mainly because the patient was taking anticoagulation. He was therefore referred to me to discuss radiotherapy. So here is his radiotherapy markup. We've defined the lesion and we've added a margin, and we've been being quite generous with the margin for this patient because of our desire to get this right the first time. This is him just a week after the radiotherapy finished. Now there's lots of bleeding here and there's lots of ulceration. I think there are lots of reasons why this patient had such a brisk reaction. He's done what I asked him to do. He stopped shaving the area of the tumour. I was a little bit concerned when I saw this, and I gave him some silicone dressings, mainly to stop him being tempted to scratch or itch the lesion. We gave him some biotin dressings to use over this to stop him touching it. And then when I saw him 3 months later, the defect had completely healed, and I consider this to be a very good cosmetic outcome from the radiotherapy for this BCC. The next patient is a 79-year-old female. She's on long-term immunosuppressive medication, and she presented with a crusting lesion in her left medial canthus. And you can see the margins of this are very indistinct. It's infiltrating into the upper and lower eyelid and also onto the nasal sidewall and cheek. The biopsy proved this to be a squamous cell carcinoma. We discussed her at our tumour board, and her options we felt were for a multi-phase oculoplastic reconstruction after a surgical resection, but the patient opted to have radiotherapy after discussion about what that involved with me. Here she is when she came for radiotherapy. You can't see it very clearly on here, but she does have an internal lead eye shield. We've taped the lid shut to allow us to treat the upper and lower lid effectively. This is her a week after the radiotherapy finished. You can see this significant erythema. There's some loss of tissue and some bleeding at the medial edge there. So this is all quite angry. She's already developing an ectropion, but I think that's a result of the tumour and also some fibrosis and scarring as a result of the radiotherapy. And here she is 3 months after the radiotherapy is finished. I'm very dissatisfied with this outcome. I think there's hypopigmentation and telangiectasia in the area, but most concerningly, she now has an ectropion of this lower lid, and she's very troubled with a watery eye. So even though we tried to avoid surgery, I have referred her to my oculoplastic colleagues to see if there's anything that we can do to improve the function of that lower lid to stop her having such a watery eye. So how do I follow patients up? So BCCs, I tend to refer back to the dermatologists if there are any high-risk features. But for an adequately treated basal cell carcinoma, patients tend to get a post-operative review, or for me, I see them up to 3 months after the radiotherapy is finished. If they've had multiple BCCs, I refer them back to dermatology because they need at least yearly follow-up because they're at risk of developing further tumours or recurrences in the next 12-month period. The same as squamous cell carcinomas, I follow them up according to their risk. So for very high risk tumours, I'm seeing patients 4 monthly for the first 24 months, where I'm examining all of their skin, the skin in the area that's being treated, and also the local regional lymph nodes. I'm then seeing them 6 monthly for a further 12 months after the first 24, so that's 3 years in total. And for patients with high risk features, such as having a solid organ transplant or being immunosuppressed, they're going to remain in my clinic for follow-up lifelong. The next most common group I see are high risk. So for those, I see them 4 monthly for 12 months, 6 monthly for until 2 years. And then at those appointments, I'm focusing on how they can keep an eye on the skin themselves and doing lots of patient education so that they present early with any skin cancers that develop in the future. So when recommending the best treatment for non-melanoma skin cancer, we need to consider the likelihood of cure, the likely cosmesis, and convenience for the patients. Well, before we get to that, let's talk about convenience. So this is a slide from Oncobeta. So this is a new treatment which is currently not available within our National Health Service in the UK, but is available for selected patients who are able to pay for their treatment. And this is radioisotope therapy. So this is using rhenium-SCT to treat non-melanoma skin cancers. Now, when do I recommend this treatment? I think this treatment is very convenient because it's a single visit. So the patient would come, We'd examine the tumour exactly if I was planning any other type of radiotherapy. I define the tumour and the margin that I want applied around the tumour. We then put a protective foil over the patient, and either I or one of my nuclear medical colleagues applies the rhenium-188 directly to the skin. We then know how long that paste needs to remain on the patient to deliver the prescribed dose, which is 50 grain, a single fraction. And then the patient will sit in the department for that duration of time, which is typically, in the order of 45 to 90 minutes for the vast majority of patients. We then remove the foil and discard the rhenium, and the patient is sent home the same day. So the beauty of this is that the patient only needs to attend the hospital once and receive a curative non-surgical treatment for their non-melanoma skin cancer. Now, and I think this is going to be particularly useful for quite frail patients who can't have surgical resection and can't attend for repeated hospital appointments. I think it'll also be very useful for patients with multiple skin lesions who require lots of lesions treated at the same time. How good is it? So we've got 6-month follow-up data from the EPIC skin study. So we look at just this column here for the, because I think we're running out of time, and the 6-month complete response rate is 97%. Now I think that's comparable comparable or better than external beam radiotherapy. And most importantly, in terms of patient-reported comfort measures, 100% of patients reported no pain or discomfort, which is obviously important in the patient group that we'd be recommending this treatment. In terms of cure rate, I'm now going to compare external beam radiotherapy with Mohs. So cure rate, external beam radiotherapy, when I'm consenting patients, I quote them above a 90% chance cure rate for either BCCs or SCCs. For BCCs, I say 92 to 97%. For squamous, I say 90 to 95%. And I do acknowledge that that cure rate is a few percentage point less than Mohs surgery. However, if you can't have Mohs, you can't have Mohs. And we discussed all of the reasons why you might not be able to have Mohs. So it's important to consider when we're counselling patients that Mohs does show slightly superior cure rates for high-risk lesions. But I think for carefully selected patients, particularly lesions in the facial triangle, the outcomes from external beam radiotherapy are potentially better. Now, recurrence risk after either treatment increases with tumours more than 2 centimetres, those with poorly defined borders, aggressive histological subtypes, or when we're treating recurrent tumours. Now, the evidence for cure is limited. Most of the published studies are retrospective. There's lack of a randomized control trial, and I think it would be very difficult to do a randomized control trial of external beam radiotherapy versus Mohs, because both the clinician and the patient will have strong preference as to which treatment they would want. And there's variable definitions of cures. When do you tell a patient they're cured from a BCC? At 12 months, 24 months, at 5 years, at 10 years? Cure is very much time dependent. And also we need to factor in the patient's prognosis from their other health problems when we're telling them whether we're likely to cure them from their skin cancer treatment with radiotherapy or not. Cosmesis. Now, I've alluded to this in the clinical cases that I've shared. I think there's a difference between patient and clinician satisfaction. So, and also there's huge heterogeneity in the published literature about cosmesis. And I think particularly clinician scoring, I know that if I'm scoring the cosmetic outcome for patients who receive radiotherapy, I tend to be a bit more generous than the dermatological surgeon might be. And similarly, I may be a little more critical of the cosmetic outcomes of Mohs surgery than some of my surgical colleagues may be. So I've got 2 published scorings of good or excellent cosmetic outcome here. So for external beam radiotherapy, good or excellent outcome in terms of cosmesis was observed in 85 to 90% of cases at 1 year. And please bear in mind that a long time after radiotherapy, the cosmetic outcome is likely to deteriorate. Mohs surgery, good or excellent cosmesis was observed in 87 to 94% of cases. Now, there are multiple different scoring tools for scoring cosmesis, and each of these different tools has different strengths and weaknesses. We've discussed observer bias, and the published data tends to be limited to 5 years follow-up at best, and it's going to be impossible to blind or randomize these comparisons. So the key findings, my feeling is that in the early stages after treatment, the cosmetic outcome after radiotherapy is better than surgery because there's no surgical scar. The late radiotherapy effects tend to develop over time, and there can be hypo or hyperpigmentation, telangiectasia, or skin atrophy. And we need to acknowledge that surgical outcomes depend very much on surgical skill and the reconstruction technique involved, and also the anatomical location of the lesion. And the patient needs to be counselled on what outcome they expect before they have the treatment. In terms of cosmesis, there are a number of limitations to the studies which we've already discussed. I won't repeat myself. Convenience. Now, geographical access to treatment is less of an issue in the UK. We're not a large country. But if we think about other land masses and access to treatment, we need to factor that in. So the travel burden for multiple fractions of radiotherapy compared to a single Mohs procedure will impact upon patients' decisions. And also regional variations in access to specialists differs, and that does differ across the UK. So access to Mohs surgery with various waiting times to be able to access treatment might direct the patient to another treatment. Similarly, access to radiotherapy is limited in various parts of the world, so patients may choose surgery just to get their cancer treated. We need to think about patient factors. So mobility, I like the institutions that I work that have access to the extral system, because patients with poor mobility can be treated very easily, even sitting in their wheelchair using the extral system. External beam radiotherapy is very good for patients who are anticoagulated. We don't need to stop their anticoagulation. And I think patients' age and comorbidities need to be factored into the tumour board discussion. When I think about patient preference, patients often tell me, they often weigh up whether the length of the treatment, whether that's 1, 2, or 6 weeks of external beam radiotherapy versus Mohs surgery, which is just one visit, but that visit can be quite prolonged, particularly if the excision is quite extensive. They may also need another surgical procedure to allow for a good quality reconstruction. So that needs to be explained to the patient to help them make a decision. So to summarize what we've discussed today, I think we've talked a little about the risks in basal cell carcinoma and cutaneous squamous cell carcinoma. We've talked about the main local treatment options, and I've told you when I tend to err towards recommending radiotherapy over other techniques. We've talked about superficial and orthovoltage X-ray radiotherapy and electrons, and I've also shown you a case of a patient where I used photon radiotherapy. I've also introduced rhenium SCT, which is a type of topical brachytherapy for superficial skin lesions. I've talked to you through the radiotherapy planning process and the various treatment schedules that are available, and we've discussed the acute and late side effects of radiotherapy. We've talked about risk stratified follow-up of patients, and we've talked a little bit about the different cure rates, the convenience of treatment for patients, and also the cosmesis that we can expect following radiotherapy and Mohs surgery for non-melanoma skin cancer. So we've covered quite a lot. I think now I've got a few thank yous. I'd like to thank Extral for giving us the opportunity to have this educational session. Genesis Care, colleagues at Genesis Care, and Peas, who provided me with some images to show you about bolus and the lead shielding required for electron treatments, and also Oncobeta, who provided me with the data about rhenium SCT. So I now think we have an opportunity to discuss some of the cases in more detail or answer the questions that have come in throughout the course of this webinar.
Thank you, James, very much. That was a brilliant overview of the role of radiotherapy. I'm very pleased to say we do have some questions that have come in. So if anybody else has some, please do send them in. Our first kind of question is, how do you decide between superficial X-rays and electrons? And when you do that decision, do you engage with your physics team if it's a complex case?
Yeah, that's a really good question. I think we talked a little bit about this, but there's a little bit more to consider. So I think one thing we need to think about and address is that unfortunately, not every cancer centre has access to both treatment and modalities. And sometimes you're limited just by what's available. And if that's the case, you have to make do with what you've got and produce the safest, best option for that individual patient within the limitations of your centre. Thankfully, for where I work, we have both options, superficial and electrons. It's mainly the two things that I mainly consider when I'm thinking about superficial versus electrons is the site, the field size, and the depth. So if it's a lesion around the eye or on the nasal alar or the pinna, I'm going to preferentially I'm going to use superficial X-rays. And the other beauty of superficial X-rays is I can treat fields of any size, which is great. Whereas electrons, for the deeper lesions, so up to about 5 centimeters, usually lesions around the lips, I'm more likely to use electrons. And any tumor that's overlying bone or cartilage may do better with electrons. The difficulty with electrons is when the fields get less than 4 centimeters. And that can be a bit more challenging in the accuracy of your modeling of the dose that's actually being given to the patient. So I would tend to use superficial X-rays for smaller lesions. Physics are always involved in my electron prescriptions. So we both check our calculations and the depth in the patient together to make sure that we're giving the best quality treatment to the patient that we can. With superficial electrons, the calculation is often a lot easier. And it's often me and one of the radiation therapists or radiographers, as we call them in the UK, that we'll just do the calculations together to get that treatment started as quickly as possible.
Brilliant, brilliant. I know you mentioned in the webinar about lower limbs, but there has been a question. Do you have any experience of doing lower limbs? And recognise you don't like to use radiotherapy, but if this was the only option, how would you treat and how would you approach these kind of patient groups?
Yeah, well, as everything in medicine, you never say never. And there's always times that you do what you say that you never do, because sometimes that is the best thing for your patient. So the first thing is it's careful counselling and very careful consent process with the patient. This is what we can hope for. Unfortunately, these are the side effects. And we need to go into that treatment, both understanding, unfortunately, the patient may end up with a non-healing ulcer. However, they've already got a non-healing ulcer because they've got a tumour that's causing increasing local destruction. So, we've got to weigh those two things against each other. One thing that I would say is that we then talk about whether it's a palliative treatment, whether we're just aiming to shrink, control, contain that skin cancer, try to stop any troublesome symptoms such as any malodorous features or any bleeding or discharge with a palliative treatment. Or if we want to still go for a curative treatment, I'm going to really fractionate that treatment. And that's why I'm using 60 grain 30 fractions rather than a 5 fraction treatment, for instance, because that gives us the best chance of that ulcerated lesion healing on the leg.
Another question. Yes, it does. Another question that's coming in. The scalp patient, what an amazing outcome. Do you see many patients with this type of lesion or multiple scalp lesions? And is this kind of your normal strategy of managing them?
Yes, it is. I mean, I'm seeing lots more of these. So I had a really difficult, challenging case to treat recently. And it's a patient living in central London. He was of no fixed abode, so he was living on the street. And he came in with a really neglected, ulcerating lesion on the vertex of his scalp. And we treated that over a 4-week period because he had considerable tissue loss. It took a long time for that one to close up eventually, but it did, just with patience, regular dressings, keeping the area clean. It probably took 4 or 5 months for the defect to close fully, but we got there eventually. So that was a really good result for him. Yeah,
that's really good. We've got a couple of questions coming about the use of imaging. So in one of the latest published papers, we're seeing an increase in the use of ultrasound for the definition of depth, and also the energy required using the ultrasound to define the depth. As a radiation oncologist, how do you see the integration of imaging into your daily practice? Most of the studies are done in the US, and I know their healthcare system leans towards imaging as a form of reimbursement, but just wondered what your thoughts are. The person who asked the question, sorry if I've misinterpreted it totally, but I think that's the gist of it.
Okay, I think that's a really, really good question. I mean, I do use imaging as part of my staging of the patient at the beginning. Particularly, in fact, one of the lesions, the scalp lesion that somebody's already mentioned, I did get a CT scan, and we did actually use CT guided planning for his radiation treatment, because I needed to be sure that I was getting the depth correct, and I wanted to be sure there wasn't any bone involvement, because if it was invading the bone, my dose and my treatment was going to be different. I'm really excited about ultrasound guided superficial radiotherapy. I think the early results from expert centres, yes, in the US for the most part so far, is that we're seeing rates of local control very similar to Mohs. And I think the beauty of that is being able to define the depth of the lesion with higher accuracy, and also to be able to adapt that throughout the treatment by doing the imaging as the treatment progresses. I think the challenge for that is going to be rolling that out. So at the moment, there's a skill deficit, and I'm very keen to develop those skills myself so that I can bring that practice into the places that I work to offer that treatment, and push the external system, the superficial radiotherapy, right to its limits to get the best oncological and cosmetic outcomes for our patients. So let's see how that evolves. The data's early, but it's looking incredibly promising.
Great. One question that's come in, and this will make you chuckle, because I don't even know the answer. What does the Sandbrook, the Sandbrook splint, where does Sandbrook come from?
Do you know what? I don't know. I presume it's all of these things. It's named after the person that invented it, isn't it? Or the person that published the paper. I haven't gone back. It's a really historical. It's been around for a very long time, the Sandbrook split.
Yeah.
And yeah, isn't it just great that I've never looked up who Dr. Sandbrook was? That's some homework for me after this.
I thought it was really.
I need to go with the Wilson method, don't I? That'll be my job for the next 12 months.
Yeah, I think that's a really good thing to do. One other question that's come in. You've talked about in depth how you look at your patients, but is there any kind of overview you can give about your clinical setup? So you've talked about the patient pathway, but just an overview of how your patients are treated in that kind of, what support structure do you have around you? Somebody's asked about that. That's great.
And I think that's essential. I'm pleased that somebody's asked about that. So first thing, all decision making is made in the multidisciplinary team meeting. At that meeting, there's all of the medical professionals you expect, the oncologists, the dermatological surgeons, the plastic surgeons, and the clinical nurse specialists. And I think to get the best outcome for our patients, the clinical nurse specialist is key. They're the person who's often seeing the patient or getting to know the patient from presentation through biopsy to treatment selection, and especially if they're meeting multiple professionals, if they're meeting me and the Mohs surgeon on different days, they're the line of continuity and can help the patient work out what they want to do and remember all the necessary information to help them make a decision. And then during the treatment and follow-up, they're obviously the thread that runs all the way through that. I think there's plenty of evidence that having a clinical nurse specialist improves patient outcomes as well as patient satisfaction. So I think having a dedicated skin cancer CNS as part of our clinical team is absolutely essential.
Brilliant, brilliant. What can I say apart from thank you for an amazing, really in-depth, comprehensive overview of radiotherapy for non-melanoma skin cancer patients, and the case studies are outstanding. The outcomes are just brilliant. Thank you all for your attention, and Dr. Wilson, brilliant. Thank you very much, guys.
Thank you very much.
All right.
Bye-bye.
Thank you. Bye.